pleasure to be here and to speak to you. And I think you'll see some similarities between what I'm talking about here and what Dr. Sinha talked about just previously. Actually, you know, as introduced, geographer by training, really focusing on population. I have no slides that include maps or anything like that, and there need to be no pop quizzes in terms of location, places, or names or anything like that. What I do want to do is give you an overview of some of the disparities that we see when we start talking about immigrant health. So really sort of as, you know, another unique or vulnerable population. So where we talked about the aging population in Ontario in the previous talk, let's talk about immigration here. I just want to give you a very brief context in terms of some of the immigrant classes, and then move on into how the immigrant effect and start to narrow down and focus on refugees here. So just in terms of providing a context, Canada admits approximately 250,000 immigrants per year. The majority of those come in under the economic class. So those include entrepreneurs, skilled labor, professionals, for example. Another 25% come in as family class. So they would be sponsored by family members already resident in Canada. And then approximately 10% come in as refugees, and either as government-assisted refugees, so those are individuals that meet the terms or definition of convention refugees as set out by the UN Convention, or as refugee claimants. So these are individuals who come into Canada and then claim refugee status after arrival within Canada. Most of those new arrivals settle predominantly in Canada's largest cities, so Toronto, Montreal, and Vancouver. So Toronto receives now approximately 77,000 new arrivals each year. And then slightly smaller numbers in Montreal or Vancouver. So Toronto actually is fairly well set up, organized. It has a long history of bringing in new immigrant arrivals into the city and providing the care and the support services and the integration that those new immigrant arrivals require. But federal policy has changed over the past few years so that there is an intent to redirect immigrants away from these three largest cities and into smaller centers. So places like Thunder Bay or Sudbury, Hamilton, Kingston, and so on are seeing increasing numbers, and they've all developed policies that are meant to retain those new immigrant arrivals. Part of it is driven by economic necessity, bringing people in that will fill roles within the labor force. But there's also the intent to make sure that they stay in those places, to stay in Sudbury or Thunder Bay, for example, rather than people coming in and then filtering away into places like Toronto. So these cities have developed these policies in order to make them more welcoming. So it's not just a Toronto thing. It is an issue that is reflected across numerous cities and towns across Ontario and literally across Canada. So I want to start at sort of a very broad perspective here in terms of looking at some of the health disparities, and that actually should be immigrant health as a national perspective. And one thing that I'll say here is that the work that I've done, or what I'm talking about today, reflects both my work at a very national scale, so using large data files coming from, say, Statistics Canada to look at some of the questions, and then more sort of detailed, in-depth analysis at a local scale. And so a lot of my work has occurred in Hamilton. So what do we see from a national perspective? And as I say, this is a very high-level, sort of broad perspective. And on average, when immigrants arrive in Canada, their health tends to be larger or higher than the typical Canadian-born. But then very quickly, within a very short time after arrival, we start to see that health decline. And this is something that's been called the healthy immigrant effect. So health high at the time of arrival, but then in general, we're seeing that decline in terms of their health status below that of the average Canadian. We see that across a number of different measures. So, you know, one of the most common ones is something called self-assessed health. And that's literally, how do you rank your own health? Is it excellent, very good, good, fair, or poor? When people answer that, they tend to respond relative to their peers. So your 90-year-old grandmother living in an assisted care facility could say, my health is very good, because she's comparing it to other people within that same facility, or her peers. in the same way that you would compare to your peers. But this healthy immigrant effect is seen beyond just this self-assessed health measure, and in terms of other measures, physical health, mental health issues, something like the HUE3, so the Health Utilities Index, which takes a look at a variety of different health indicators. So we see this consistently. We see it in Canada as well. We see it in the US. We see it in Australia. We see it in Great Britain, and so on. Out of that broad sort of immigrant population, refugees are most likely to have some of the greatest health needs. And as I say, I'll drill down to that group a little bit further in a few slides. And you're also at greater risk of experiencing that health decline if you're a visible minority within Canada. So what about the healthcare utilization then? So picture you've got declining health status over a relatively short period of time. You would expect or hope to see that the use of healthcare facilities is increasing. So greater need leads to greater use of healthcare facilities. Not necessarily the case. Again, from a very sort of general type of perspective, on average, we see similar use patterns amongst immigrants to the native-born Canadian population. But we don't see an increase in the use of, say, physician services or hospitalizations, whether that's a walk into the ER or an extended period of time within a hospital, to reflect that increased need. So the need for healthcare is increasing as healthcare goes down, or as health status decreases, the need for care increases, but we don't see that same increase in terms of use of healthcare facilities. Again, visible minorities are at greater risk. They're less likely to be using these healthcare facilities. And one thing that we typically see, or really more specifically don't see, is a more limited use of preventative services amongst new Canadians. They're less likely to be engaging, say, in mammograms or Pap tests and so on. They're not necessarily aware or engaging in the use of those preventative health services. So given declining health status and greater need, is this really appropriate? Again, on average, different literature, different researchers identify that immigrants tend to receive poor health care, and in part because of various barriers to care. So one that was identified in the previous talk was around language. How do you converse with your doctor? But it's beyond that too, in terms of how do you converse with the receptionist. And when a follow-up appointment is made, so you have somebody that's speaking English or French on the phone, how does that translate into speaking and conversing with the person on the other end for that follow-up appointment? There's also a broad variety of barriers to care around social or cultural roles. So women's accessibility, the women's use, or the social role in terms of who is able to talk within the doctor's office, for example. Knowledge of the system, identified in the previous. But even something as simple as transportation. You're a new arrival here in Toronto. How do you navigate from, say, the West End and Etobicoke into the downtown when you're unfamiliar with the system and you can't ask a TTC driver or operator how to get there? So even something that we take for granted in terms of navigation around the city becomes problematic and more difficult. Issue of insurance is huge amongst new arrivals, and I'll come back to that in a moment, along with mental health issues. And we've done some work around sense of belonging, integration into the community amongst new immigrant arrivals, and how important that is for them to feel a member of the local group or local community in terms of their own mental health. Refugees. Take a look, and we have a diversity of sources for refugees. So this is literally a handful of some of the largest sources of refugees coming into the country at this time in our history. Refugees more likely to experience these declines in health, and they certainly exhibit greater vulnerability, greater disparities in terms of their health status. So the question is why? And yes, it's a relatively small population. As I said, it's about 10%, but it's still very significant here. certainly more vulnerable population from a number of different perspectives. So first of all, barriers to care. So some of the things that I mentioned just on the previous slide tend to be magnified amongst the refugee population. In part, new arrivals don't necessarily have that built-in community and support network or family and friends that they're able to draw on when they arrive. Security is a huge part of how these new refugees feel if they're embedded within the local population. And that differs, or that security differs importantly by their refugee status. So convention refugees are eligible for a series of programs, English as a second language programs, access to community care services, some limited health type of insurance. But for a refugee asylee, a claimant, they're much more tenuous. They don't know if they're going to be here in Canada for any extended period of time because their case is being heard. And over that time, they can't access community care centres typically. They can't access much of our welfare. They have some access to Ontario Works as an income source, but that's typically insufficient to meet their monthly or daily needs. So the status of refugee arrivals is a huge issue. Health versus other short-term needs, such as housing or food or employment. What we've seen is that healthcare actually is relatively low on the priority list amongst new arrivals. What's more important, making sure that there's food on the table, making sure that there's shelter over their head, for example, finding employment. And then they can start to consider where their health is and what they need to do. Refugees often experience violence, and coming from refugee camps, for example. The social roles mentioned in the previous slide, but certainly those social roles, who is able to act, who is able to talk, what role do they have in society. Mental health, we see greater mental health needs amongst refugees, often coming in with existing health issues, and this population often lacks a voice here because of their relatively tenuous type of situation. They're not the people, they're not wanting to speak out and sort of raise issues. Again, in part, fearing for their own security and their ability to remain in Canada. Another issue that reflects the disparities that we see within their own health reflects the sort of journey to care that they've taken, the journey to health and the journey to Canada that they've experienced. So their own health reflects really the sum of the different parts in terms of their history and their arrival here. And we could break that down. So what happened pre-journey? What happened to them in transit? What are their experiences? Have they lived in refugee camps? How long have they lived there? What sort of violence or what sort of living conditions were they under? Did they have access to care in those refugee camps, for example? How did they actually get to Canada? How long did it take, for example? And then post-arrival healthcare, there's challenges for both the client as well as the provider in terms of finding or meeting their own healthcare needs. And I'll come back to that in a moment. So on average, refugees tend to have lower use and more tenuous contact to healthcare than immigrants. So just those economic or family class immigrants. So if we separate those three broad classes, refugees tending to have the least contact or the most tenuous contact with the healthcare system. In part, again, it's going back to that history. So they may lack access to health care and primary health care over the time that they've taken to arrive or it has taken them to arrive in Canada. Also, over the time of their journey here, that there may be that lack of health care in getting here means that their health care and contact with the system is often disrupted, and the management of any sort of care becomes problematic or disrupted as well. So it's piecemeal and trying to put those different pieces together over a period of time. Another problem that we see that creates these disparities and this idea of a vulnerable population is really the very disjointed nature of immigration and settlement that we experience in Canada. It is a good system, and it is a model system, but as pointed out right at the beginning, there's still problems in terms of a good system. And from a refugee or an immigration perspective, settlement is a federal issue. And so the feds, pretty much say, well, we've got the individual into Canada, we're done. Our role is over. Healthcare becomes a provincial issue, and social assistance, housing, and so on is a municipal issue. So you've got these three different levels of government that are supposed to work together, but you and I know that they don't necessarily work together, that there are problems in terms of communication and that division of services between the different tiers. Health coverage is also problematic. So, of course, healthcare is typically or is a provincial responsibility through OHIP. For refugees, they used to have something called the Interim Federal Health Program, the IFHP. That was disbanded by the federal government approximately 2.5 years ago now. And so refugees, when they first arrive in the country, and these are convention refugees, had no access to health care. So they would be showing up at the ERs in town and presenting themselves there in terms of seeking care. Who pays for that ultimately? It's not covered under health insurance, so it's the hospitals that are picking up the dime and then ultimately sort of flowing back to us as healthcare payers. Access to OHIP is limited and residency within the province for 3 months. But even though on paper individuals have access to OHIP within 3 months of arrival, the reality is different, that people may not know how, these refugees or even more broadly immigrants may not know how to go about accessing it. How do you get a health card? Where do you find it? How do you go about doing that? So it becomes really problematic in terms of providing health care. The one good point of information is that Ontario has just picked up that sort of interim type of coverage. So it is, refugees do have that coverage now once again. But in part, it's still incomplete and still some problems with that system. The alternative, of course, is private health insurance. It's the cost of that. How can people afford to pay when, if they're reliant on Ontario Works, that there's barely enough money to cover the monthly rent associated with their with staying here. Another issue is in terms of isolation, and we heard something related to this in the past talk. So social and cultural isolation leads to significant barriers in terms of healthcare. They restrict that interaction that people can have and constrain individuals to their homes. So they lack that sense of community. They aren't able to participate in that. In part, there may be social and cultural restrictions or roles that determine how they participate in the broader community. But oftentimes, what we've seen in Hamilton, for example, is that new arrivals are placed into particular apartment blocks. And you would see the same thing here in Toronto. And that creates a sense of isolation when there is the inability to engage in a broader community, whether it's people that speak the same language or the broader fabric of the local community. So very limited housing opportunities, for example, that we often see, that creates that social isolation. So in part, if there is social isolation, there is that inability to get out into the broader community and participate. I see that I'm out of time. I'll just say that there are a variety of different provider issues. So, we've talked with providers in the community around their role and how they participate and work with these clients. And large part of that is around the history and getting to know that. But again, it can still remain very disjointed information. So it's led to stressed and overloaded organizations. I'll leave it at that. You can read that slide while I sit down and we move on to the next speaker. Thank you.